DJ DiversiTrials. Yeah, we're coming together, beat by beat, in the streets where the heartbeats meet. Step up, step in, feel the rhythm of change. From the corners of the world, we're rearranging the game. Forces loud, spirit strong, we roll with a diverse crew. Breaking barriers, building bridges, anything we do. Rise up, unite, let's make it right. With every word we speak, we light up the night. Light up, hell for all is our call. Let's break down the wall. Together we stand tall. City laws, city lights to rule. Sights we're spreading the word. Every boy, every girl deserves to be heard. Equity and health, that's the wealth we distribute. Striving for inclusion, there's no substitute. Drop the beat, not the hook, let's celebrate. Raise the stage, till the breaks, no time to wait. We navigate the challenges, we innovate. Diverse minds collaborate to create a better state. Yeah, DJ Diversity Buddy out.
Wow.
Yeah. So DJ DiversiBuddy, right? Yeah, everybody's gonna have to let us know what you think of DJ DiversiBuddy. Thank you all, everybody, throughout the course of this first podcast. Really, really appreciate everyone showing up and turning out for us, as always. We couldn't be doing what we're doing without all your guys' support. So absolutely. So let's just get it kicked off. I think everybody at this point has probably already seen some of the stuff we've put out. You know, Dr. Fox is a huge fan of hitting up coffee shops and starting interviews with random people. So one of the first people we actually interviewed, I would say actually the first person we interviewed with DiversiTrials, when we were all together at Houston. We met her at a coffee shop called Siphon, and it is the Miss Raven Hicks. Welcome, Raven.
Hello.
Raven, it's so good to see you again. Oh my,
Yeah.
I don't have coffee this time.
I know it's kind of late for coffee.
That's okay because I have this.
Oh, that's cool. There you go.
So not good for you, but I have to do something.
And I greatly appreciate the background that you threw together. I love that you pulled that from the website. It's fantastic. We're gonna have to get you like a hoodie or something too, so you can rep our gear now.
Absolutely.
But anyways, so Raven, let's introduce you. Introduce yourself to the community.
Sure. So my name is Raven Hicks, and by trade, if you would say, I'm a business analyst for a health tech company. However, I was in the military for 5 years. I was in the Air Force where I served as a pharmacy technician, and I served in Tampa and at MacDill and at Lakenheath in England. And I've since gotten out of the military. I finished school, got my bachelor's in psychology with a double minor in sociology and criminal justice. And then I moved to Houston to go to Texas Southern University, and I got my master's in administration of justice. And it's at those two universities where I've done most of my studying, where I've done all of my research, all of any clinical research that I've done was through my universities that I had gone to, and where I had discovered a real passion for just learning, a real passion for doing any type of trial studies, looking at peer review articles, and so much so that it continues on within me today. I was doing something earlier today with clinical research. So it's actually, it's fun. I'm a little bit of a nerd when it comes to that. So that is me in a nutshell.
We're all nerds here. It's fine. Everybody watching's a nerd too. So
Yeah, I'm sitting here thinking, oh my, like I got goosebumps here, but like listen to your story. We met at a coffee shop, never knew it. She had this awesome monitor extension. I think that's what started the whole thing. You have this extra screen on your monitor. I mean, come on, that serendipitous. I love it.
Yeah. And then I know when we talked at Stipend, you know, and you have this, it was really like a cursory background with research. You know, it wasn't this expansive thing. You know, with most of the people we obviously engage with, you know, DiversiTrials, Dr. Fox and Zanawi and myself, it's heavy clinical research industry all day, in and out. So it's really insightful getting like this completely different perspective, and someone who, you know, we found to be so incredibly passionate. We cling to you, and I hope you cling to us as well. And it was amazing just to see this inspiration and this motivation you had. It's truly phenomenal. But I mean, we shared our mission with you, and trying to help address these healthcare disparities in underserved communities by means of clinical research. Because I know one of the things that we discussed when we were there is, and it's always what I say, is that, you know, we have to be there unconditionally for these communities and help educate them and make them aware of how valuable their participation is in clinical research trials, because that's going to create the data that in turn creates that healthcare equity for them in the long run. But we got to give them the options. And I think that's part of the issue, is they haven't had the options, or people just ignore them because it's easy. I don't know.
I could agree with that. I do feel like sometimes it can be ignored. And I'm not even sure if I even got a chance to share with you all that I had worked for the University of Houston in the Healthy Start program, and where we were helping with like maternal childcare rates and things like that, because obviously women of color experience more racism and things like that as it is pertaining to the healthcare industry. And unfortunately, they did not get funding for 2024 to 2029. So now you have that. I think it has gone to Harris County, if I'm not mistaken, is where that funding has gone to. So hopefully they will continue on with the mission that University of Houston started and Healthy Start with that program. But there were so many things that program offered to women, to men, because they had a fatherhood program as well, to be able to get those resources out to those individuals in those underserved communities. And I'm a firm believer in everything that you've done in your prior time sets you up for something in the future. And today I had the opportunity to speak at my current position about that with the VP of content, because now they're going to be creating content for maternal child care death rates and things like that, so that we can get women of color to go into those appointments early, to seek prenatal care early. Yeah. So that they're able to get, you know what I mean? So we can kind of cut off some of those things before they start. And just to encourage those women to go after, you know, getting that healthcare and getting that support. And what does that look like? Just making sure they have advocates, because there's been times I had to go into doctor's appointments with my girls that I was seeing who are in those programs, to actually give them, you know, that extra push and help that they need to advocate for themselves, because some people don't know how to do that. And when you think about an underserved community, some of them don't know how to do that. And sometimes you're that voice, you're the only voice who can do that for them. So just being able to be a part of that, and then even just being able to be a part of this, for me, I'm like, this was all a setup for what it is today. So I'm extremely excited to be here. I'm so glad that you all are doing this, because the need is great, and it's a very needed area. It really is.
So when you're talking about like maternal morbidity rates too, so everybody in the audience is aware. I know there's some who are probably much more diligent and probably have current year numbers, but I know back in 2022, the numbers I found from the CDC, for Black women, it was 2.6 times greater than, you know, white women in comparison for maternal morbidity rates, and it's kind of alarming, right? But to that point, I think also the big aspect there is the lack of trust, not just in research. Like, we know, everybody in the research industry should understand why there's a significant lack of trust, because once trust is broken, it's hard to put those marbles back in the jar, so to say. But that trust in the research carries over to the healthcare industry just the same. And then when, you know, I could imagine, right, you know, as a Black woman, if you're seeing statistics that your community is 2.6 times more likely to have, you know, maternal death rate than a white woman, that doesn't make you feel confident in the healthcare that you're going to receive.
No, it does not. It's very scary, in fact. And as I was working with my company today on like just trying to be able to get that information out and what does that look like, we were able to read through some of the content they have already created. And we were essentially like, okay, yes, X this out, X that out. That's not needed. This isn't going to convey well, because it's not people of color that's writing these things. So
Right.
how are you going to be able to convey this message to a group of people that you don't even have any contact with? So it's very interesting, just trying to even get out that information. And then, like you mentioned, the trust that ends up being broken, because when you start thinking about the socioeconomic status of people who are not able to, like they don't have access to some of these things. And I'm like, okay, who is our target audience? Is this, people, women of color who have a significantly, higher economic status or have the resources to be able to do these things? Or is this people who are on the lower end of that spectrum and maybe they do have 2 children or they have 3 children? And how are you going to get them to be able to get these things? And like, what is that going to look like going forward? And the large majority of those women, if they're on a lower end, they're not going to be reading through the article in an app to get information about things. Or if they do, it's going to be, you have maybe 6 seconds or so, maybe 2 minutes to grab somebody's attention so they can get this information. And if they're really busy, it's probably going to be less likely that they're going to be able to have access to that. So now what's our next move to assist in that?
Yeah. In clinical research, Raven, they have these things called centralized campaigns where like the big sponsors and the pharmaceutical companies will hire advertising agencies on a national level to create special advertising for a trial. But it's centralized. It is not customized to the communities that it goes into. And so it often runs into challenges just like what you were saying. Like the people who are running these advertising campaigns, they have no idea what the community needs. They're just trying to do it on a big, broad scope. And I think that you're exactly right when it comes to healthcare as well. Sometimes, unless you have that community local touch where you have an understanding on how to build that relationship or how to build off of a current relationship, you're done. Nobody's going to listen and it's not going to work. And we're wasting a bunch of money.
Yeah. I mean, that's a big thing that we talk about as far as, I guess, the outreach aspect of the clinical research industry would be community engagement is what's widely used. And, one of my big pain points that I hear everybody else talk about is like this return on investment with community engagement activities. And it does drive me a little bit crazy. I mean, I understand the concept, as the CEO of a clinical research site organization, it makes sense. We have to be able to track, how much we're spending and what that potential return is. So we're not overdoing it and then end up bankrupting our company.
Right.
But the frustrating part is that it becomes very transactional in those relationships, and people aren't dumb. They know when they're potentially being taken advantage of. And I think if that first approach to anybody, and you want to truly be there to help them, but if your first approach is like to maybe try to get them into a trial, you're doing it wrong. These community health fairs are fantastic things to try to do outreach for the community, provide health screenings, and get people information about their labs and kind of where they're at. It's a potentially great service that you're providing, especially for people who don't have, PCP and they don't have good health care. But it becomes a transactional thing even then, because they understand that you want their healthcare data. They want your information, and they're going to contact you and send you emails and blow your phone up with text messages for potential trials and stuff. And it just doesn't really establish, I think, a great relationship. It's not a good way to build trust. That's why I even threw unconditional under my name, because that's been my buzzword. I think that's like going to be my catchphrase. I'm going to get that tattooed somewhere on my body. But I mentioned it already at the kickoff of the podcast. Like, we have to be there unconditionally for the communities. And to me, this aspect of reaching out and it really should be grounded in mostly education. We want to combat healthcare and research misinformation just as much as we want to educate people on the importance of their own healthcare and their participation in trials and research. And to your point, educating these women on receiving proper care and the need for even going to the doctor and getting that prenatal care. I know ARPA-H, so it's the Advanced Research Projects Agency for Health. They have it's what's called the Sprint for Women's Health campaign. It's relatively, I think they initially announced it back in like February, but they continue to have updates, but they're essentially giving $100 million that they're dedicating to two separate. There's the Spark and Launchpad. So Spark is early stage research and Launchpad is late stage research, but it's specifically focused on women's health. And I don't know what's going to come of it yet at this point, obviously, but I would absolutely love, obviously, I think all of us would love to see women's healthcare research with a heavy focus on doing it as inclusively and as diverse as possible.
Right.
But at least to that aspect of when it comes to women's health, like we're talking about, maternal morbidity rates, that aligns right there. One of the other things that's a glaring disparity, I found a study from the Medical University of South Carolina, and it was with rare diseases. And I think it was like 90% of people with lupus were women, and the majority of those women were, Black or Hispanic, which is shocking.
I wonder about a lot of these things in terms of like where the onset of where some of these things happen or where they occur. Some stuff I've noticed that it matters about the area, what's in the soil of that area. Sometimes I know that there's been there's different issues with the environment, if there's plants and things like that are around. I know there was a lawsuit here in Houston once upon a time because there was an influx in cancer, I want to say in the 5th ward of Houston. And there was a railroad that ran through that area. And those people there was like a high, possibility those people ended up with cancer. So I want to say they did like a class action suit or something like that against them. I'm not sure exactly what came of it, but it's like things like that. I always wonder, is that something that is contributing to these, to some of these issues and some of these healthcare issues as well, especially as it pertains to asthma and autoimmune diseases and stuff too. And I always wonder, like, okay, well, what is the fix? If it's in the soil, how do you fix these things? You can give somebody medication all day long. What is the root cause? How do we fix the root cause of these things?
Yeah, you're absolutely right. And yes, I guess the short answer is yes, it does have a huge factor. And I think everybody knows that. Dr. Fox and Dr. Danawi are public health experts as well, but
I don't know about that. But
yeah,
you're absolutely right.
Yeah.
But I mean, when you look at right, so not just whatever the flower or plant thing in Houston area might have been, but through most larger cities throughout the U.S., I mean, you'll find like a denser population of minorities in like right around like industrial complexes or just downwind, just downstream, where things are really, really underfunded. And
try rural areas where they do crop planes and fertilizer waste. And
right. And
exactly.
to that point, I actually ran many years ago a study in the Gulf region here, like in the Houston area. And you will probably relate, Raven, to that because you live in the Houston area. But anyway, the bottom line is that we actually found that people of color, even though they were be whites and Hispanics and blacks and all sorts of racial and ethnic categories in that region, but we found that people of color, and more specifically so Black people or African American people, were actually more. They actually developed lung cancer more so than others from exposure to those, industrial sites like, next to Leak City and stuff. So it's interesting to know that even though they were actually an equal, let's say, breakdown of racial and ethnic categories in that region, but the surprising find was African American were actually, developing more or ending up with more incidence of lung cancer, and access to healthcare was actually a big thing right there and then. And then, they still understood that they lived in a highly toxic environment, but the taboo, the fear, the stigma, you name it, and access to healthcare just played a big role in the incidence of lung cancer in that community. Surprising. So back to your point again, Mitch, health education, health education, health education, health awareness, health awareness, health awareness. So we need to actually bring up health awareness to the forefront and talk about all sorts of indications, conditions, diseases. Build that trust, build that friendship, show that you love them, show that you care, show the passion, and then if you want to match them up with a clinical trial, that comes later.
Yeah, I mean,
And
it's. Go ahead, Fox.
I was just saying, and what you don't want is some person to fly in on a golden helicopter into the community, tell people what to do, and then fly off over to their suburbs or somewhere far away. That's no way to feel like you're connected to a community, and there's no way that they're going to trust you because you're literally creating this divide between what you're trying to accomplish and that community's objectives.
Right.
Amazing. To that note, go ahead, Mitch.
Yeah, what I was going to add there too is like we can do one thing, and with DiversiTrials, we're trying, right? We're going to help try to bridge this gap with research and healthcare disparities, and build these consortiums of our colleagues throughout the industry to drive better research in healthcare. But there's other than providing this data and helping do the research, when we talk about like where people are from. That's something, that granular information that I'm really pushing for to help bridge this gap between, clinical research, healthcare research, and then that public health aspect of, environmental research and, where you're living, where you're from, and what factor that might even have on these different medications you're taking and your potential outcome. But there's a relatively minimal amount of stuff that we can do to impact, like, say, redlining, for example. When we talk about like systemic racism, and that's the kind of stuff we talk about. Like, it's not, where are you going to move, right? It's expensive. That's not easy for me to sell my place and even move. You know what I mean? Much less these people who are in underserved communities and underfunded, underdeveloped, and they don't have the resources. And, you're stuck there because historically speaking, these minority groups were pushed into areas that the white people didn't want to be, essentially. So how do we get out of that place is a whole nother problem that, hopefully we can continue to help support, at least statistically, to continue to show these disparities, and we can continue to outline the negatives that we can find across the board with these groups. But yeah, I know you mentioned lung cancer, Hadi, and I know, Raven, you had brought up asthma, and I looked up some numbers regarding asthma and healthcare disparities there. So 30% more likely for Blacks to have asthma that was like from 2019, so I'm not even sure what it is now. 3 times in 2020, the numbers were 3 times more likely to die of an asthma-related incident. And then in pediatric patients, which was really, really alarming and disheartening, it was 7.6 times greater for an African-American child to die of an asthma-related incident than a white child, which is a wildly greater rate.
Unacceptable.
I got to ask, Raven, so these are some obvious, huge health disparities. So we have our populations of color, our women of color, the Black communities. They have these higher percentage rates of prevalence for disease. How many people in your network or your community or your family have been part of a clinical trial or have actually participated in the development of these drugs that are obviously trying to help the same people who are experiencing high disparities?
I know none.
Yeah, wild.
I know none. That is, and I'm just now thinking about that, as you know what I mean? I'm like, oh my gosh, I have like, and as I think about it, so my biological dad, his mother, and sister all died from lung cancer. You would think that I would know somebody who would, you know what I mean, who would have participated in some sort of trial with those type of, with that information. But also to, I think, Mitch's point earlier, with the lack of trust and everything, my biological dad and my grandmother, they were not from the U.S. They were from Honduras. So they were immigrants when they came here. And you have to also think about the lack of trust that they have, because I'm an immigrant. I have to fly under the radar. I can't go to the doctor. And then you tie in every other socioeconomic status factor that you could think of. And then you have the perfect storm for somebody to pick up habits like developing smoking. And then, you know what I mean? And then now you have nothing to, you know what I mean, to catch you if in the event you caught that you have cancer. And by the time my dad found out, it was last year, and it was already stage 4. He passed in January. So he had probably already had it, of course, all these years, but he had never known. And then all of a sudden he's stage 4, and then boom, there's nothing, that they can do at that point in time. So
then it's terminal.
Exactly.
Yeah,
So now, I don't know anybody who had been in any clinical trials.
So there absolutely is a stigma around participating in clinical research, for sure, which is something that everybody needs to do better about, being comfortable talking about research and knowing that it's acceptable to participate in research. It doesn't mean you don't have healthcare. It doesn't mean you're sick and dying necessarily. You're not contagious all the time. But I think the only exception there that I tend to see is participants in, like oncology trials or like certain rare disease studies, because those advocacy groups are so significant. But you normally don't find people who are going to be like too outgoing of like, hey, I'm participating in this hypertension study. It's just, most people aren't advertising their level of unhealthy that they may potentially be, or, they just don't feel okay with being ill and seeking clinical research as an opportunity to find a treatment.
But that also ties back, especially in the community of color, it ties back into this whole, we can't say anything about what's going on to anybody. It's always this, what goes on in our house stays in our house type of thing. But that also ties back to racism and things like that too. If you say anything to anybody, then something bad may happen. You may be taken away. I may be taken away.
The
like
fear.
The fear. And so people won't say anything and then they won't say anything out of, and then into a grave, because they don't want to say anything about it. And then, like you mentioned, participating in clinical trials is something that's, I won't necessarily say it's taboo, but it's not anything that we've ever heard of anybody doing in the community of color. So what does that even look like? And then if you do get somebody who does it, you have to then fight off all of the naysayers who are like, they just want your information. They just trying to steal this. They just want to, you know what I mean?
Yep.
Or you think about the Tuskegee trials that happened.
Oh yeah.
So why would I, you know what I mean? That epigenetics that's in us, that fear that's instilled in us from something that happened to an ancestor or somebody that came before us, and now we have, you know what I mean? Yeah. So there's a lot of things that goes into that, of why somebody chooses not to. And, hopefully within DiversiTrials, the goal will be to break that down and hopefully have a team of people that you can send out who can trust. They can trust whoever it is that you put in front of them, that this is not going to happen. We're here with you all the way, so they can actually feel comfortable enough, because God forbid, you get somebody that they're comfortable with and then you take it away. And then now that's
you mean like when there's cut grant funding and that disappears, and now you're going to have entire populations who they're finally getting help, and now they're not going to get the help.
Exactly.
So So to that point, and this is one of the biggest challenges, with community, the community of color. And I don't know, Raven, if I shared this with you, but I was actually born and raised in Ghana, West Africa. And one of the biggest challenges there is that those medical missions go one time, they show their faces one time, and they disappear. So they created more of a distrust with the system. So if you want to really get somewhere, you have to always unconditionally be there, unconditionally, like Mitchell said. Be there, show your face. Show your face unconditionally, be there unconditionally, repeatedly, because people do not, any person would not trust someone, a foreigner or a foreign face come to say something to them. So anyway, the bottom line is that consistency and to build this trust should always be there.
And I'd like to. I was just going to reference LaShawn Sanders because this is perfect. What happened? Do you guys remember LaShawn's story? She had that friend who. So I'm so sorry, LaShawn, if you hear this. If I butcher it, you can yell at me, but I will do my very best. But LaShawn had a friend, an African American woman. So she went to the pharmacy to get a prescription. And she got the prescription and she looked at the label of the prescription and it said right there, may not work in African American women because they were not a part of the clinical trial. So they did not know if that would work, but she was prescribed that. I could only imagine if I went to my doctor and I got a prescription and that prescription was filled and it says, hey, this may not work for you. I would be like, what the heck? And so LaShawn told her, she said, it's up to us to fix that. We've got to be a part of clinical research so that we can help our community to have better medications for everyone.
Yeah.
I hope I didn't mess that up, LaShawn. But
that sounds right.
That's about right.
I'll vouch for you, I guess. So while we were starting DiversiTrials, and one of my best friends told me that we were having a conversation one day, and she said that you deserve someone that stays, like in the sense of being supportive, right? And it just like clicked with me, and I'm like, that's absolutely it. I mean, that's what we need to do, and what we're trying to do with the communities and the people we want to help too, is they deserve someone who stays. And like that's Hadi's point, you have someone show up one time, or, you have someone show up to do a health fair and a screening, and then you just never hear back from them until maybe you qualify for a study and then they want you to come in because they're going to make money off of you. Well, that's not great. You're not building a relationship based on trust at all. You're not actually engaging with those people and helping them and supporting them. But it takes a village. It's certainly not easy. And I know the other thing I always talk about is how I know it doesn't matter. Like Raven, you've met me. I'm all about hugs, and I'm a giant teddy bear. Apparently I intimidate some people to begin with. I think it might've been the Batman thing that I had going on, but not everybody's going to feel comfortable. Doesn't matter how welcoming I am, right? I might want everybody to come and be able to care for everyone, but not everyone's going to feel comfortable coming to me for care or to talk about care or talk about their issues. We're talking about even the stigmas, Raven, you mentioned the stigmas behind talking about healthcare and really anything else. But I think what we're seeing now in the industry in a positive way, industry as a whole, is an increase in trying to push people to be able to talk about their mental health and their mental well-being. But to that point that you made, that stigma is like, we are already behind in mental health care across the board, but it's exponentially worse for minorities because that stigma is like so much greater to be able to be comfortable talking about your mental health. For men, it's not easy too. It's like, oh, rub dirt on
mental
men.
health's tricky.
Yeah, you're not allowed to cry, all kinds of stuff.
Yeah, let's do comments because we're about 30 minutes in, and for first and
totally
foremost,
ignored comments. We've been busy.
So LaShawn is on the podcast, and it was not just African American women; it was African Americans in whole, men and women. So there are disclaimers on prescriptions saying that we can't guarantee this works in these populations because they are not a part of the trial. Thank you so much, LaShawn. We've had so many others here. I guess we should start at the top. So
let me grab this one too.
Go ahead.
So Kelvin Peak, Kelvin, amazing. I love that you're always on, my man. This is a great point too. So aside from like clinical research and medication studies, when we also talk about like medical devices, pulse oximeters have fallen short for a long time. But there's a lot of like just diagnostic tools. Even stuff like let's talk about other aspects too of like AI. I know people probably followed Tesla and smart cars and self-driving vehicles to a degree, and without a doubt, it's been called to attention that like, oh, these self-driving cars are like racist, right? They don't detect like the black mannequins that move in front of them, but they'll stop for like all the white ones. It's absolutely mind-blowing. And I think a lot of it, though, just has to do to a degree with ignorance in some of that aspect. You're only testing it on one thing, and you're not putting that forethought into what in research is managed under ICH, International Code of Harmonization, ICH E8, which is this quality by design aspect. And that's one of those things that DiversiTrials actually helps sponsors with, and CROs with. If you're developing protocols or you're developing a study, we're happy to collaborate with these individuals to try to make sure that from that quality side, you're considering all these other options and you're considering all these other people, and we're being as inclusive as we can. Let's see.
So Raven, as we go through these questions, I would love to know your comments on these and how you feel about them. I'm seeing some stories about how some people were in clinical trials and decide not to. So we'll just, if you want to drive, Mitch, we'll just go down these questions, and I'd love to hear Raven's comments.
Yeah, here's another one from Kelvin. Lack of trust due to the continued use of biased clinical algorithms and assessments of health outcomes. Absolutely.
Mm-hmm.
And
Absolutely.
it's interesting of the assessments that they do, because some of the assessments I know that we used to do when we would go out to visit our participants in our program, they did tend to be a little biased. They had to go back to the drawing board with a couple of the questions to take out things that looked biased or any of those things, to include today, just with my current job, having to go in to make sure that things didn't appear biased, and you know what I mean, having to make it all encompassing, because if you don't, then you kind of end up with I'm drawing a blank. Research it happens whenever you get like a sample, like a biased sample of some sort, like you essentially getting sample bias.
It's sample bias. Yeah.
Yes, and you want to avoid that as much as possible, especially in a lot of the clinical research that's being done.
Yeah. I don't know that we need to touch too much on this one because we beat it. Hopefully, everybody else who's attentive, if you're on the podcast or you're watching and you don't know what redlining is, historically speaking, strongly encourage you to go ahead and look into that. It will, I guarantee it will shine a big light on something you didn't even realize exists, especially when we talk about like systemic racism and how to maybe move forward. But it's not that it's extremely difficult to be able to move forward. So
let's stick with LinkedIn user, which you find out later is Alicia Moore. Hi, Alicia. Thanks so much for coming. So Alicia said, I had a person in my family who participated in a clinical trial, but she decided not to continue in the trial. So I think this comment happened when we were asking you, Raven, if you knew anyone who's part of a trial. So Alicia, she went to that. And if we go through the comments further on, so Gina. Hi, Gina. So good to have you here. Gina confirmed over in Long Beach, California, we have a really big incidence of immigrant fear in Long Beach, California, and that makes sense. That is definitely a population that can be vulnerable, especially when it comes to healthcare and healthcare assessments, and specifically research, especially research. I can't tell you how many people love to consider doing research on undocumented people. Yeah. Let's just state it. That's a lot of people will take advantage of that, and we have to be very careful with those populations.
There was, I remember a study that was done a long time ago in I want to say it was California, of the Hmong people. I think it's HMONG. And they were kind of essentially taken advantage of within that whole clinical research and things like that. So like you said, it can be a very, very vulnerable population as well.
Mm-hmm. Yep. And same with Native Americans. There's a lot of mistrust in any kind of a government work or research work with Native American populations. It's pretty sad.
Yeah, I mean, rightfully so, though. I mean,
I say it's sad, but it's fully justified.
Well, yeah, once you break that jar, it's hard to put all those marbles back. 100%.
Yep. So this was Gina. So Gina and Alicia, they're talking, and they say, "Do you know why she withdrew from the trial?" So as Hadi said, I wonder if that site was not there for her. Just get back to the community engagement, transactional. Hey, you want to be in a trial? Okay, we'll see you later. Go on to the next one. Like Golden Helicopter or whatever it might be. Maybe that was part of it.
I can add a lot. I mean, as a CRA and going to a bunch of sites, formerly, that's something I saw across the country where most sites were really, really diligent about having, especially nowadays, like lately, having these like texting systems and continuing to do outreach, small touch points, like, hey, just checking in to see how you're doing. We always provide patients like 24-hour access numbers, and you know who to call. Hopefully you develop a good rapport and you see your regular like clinical research coordinator. It's not just some new person every time. So you can build those relationships, but it absolutely does happen, especially at sites where they get overloaded. And if you're only coming back like once every 3 months for the study, and you see them, and then 3 months go by and you have an appointment scheduled, you might get someone to call you a heads up, like, hey, you got an appointment, you have a window coming up, what day are you going to be able to make it in between here and here? Because you've got a 14-day window that you can come in for your visit to stay compliant. But they're just calling you at that point to make sure you come in to stay compliant with the study, not actually there for you. at least that's how it comes across, right? Let's go back. Yeah, so we did have.
Yeah, this would be Alicia. Alicia's coming back. So Raven, I wonder, what do you think about this comment?
That was actually going to be, when I saw the comment, that was actually going to be my first thought, is that there was probably some skepticism about the adverse effects that the drug is going to have on her. And she probably, and I understand that there's a way to have healthy skepticism, but when you start thinking about like, okay, well, what's going to be in this? How's it going to affect me in the long run? And there is no support that shows what's going to happen in the long run. I feel like that will scare people away from being able to be involved in something when you don't know how that's going to affect you, especially depending on what the issue is that you're even being treated for. Like if the side effects are going to be worse than whatever, you know what I mean? I don't want any parts of it if the side effects are going to be just as bad as having whatever it is that I may have an issue with. And that it can be scary for people as well. So I can understand that that issue. And I also understand that sometimes that you're in this because like there's a greater need for it, but you have to kind of weigh those options, as if every individual has to be able to weigh the option of what that's going to look like.
Yeah. I mean, she mentioned too that she's healthy. So if you talk about like a healthy subject trial and you're talking phase 1s, I mean, you don't know the side effects necessarily at that point. That's part of what you're actually in the process of discovering. How it's going to interact with, if you're eating food, if you're not, kind of seeing varying dose ranges to see what's safe, see what's tolerable, evaluating pharmacokinetics and all that fun stuff.
Because that could be an issue. And Dr. Fox, I'm sure you and Dr. Denawi probably know about this, because even so, let's just take, generic warfarin and Coumadin. You can't have alcohol. You can't have a whole lot of heavy greens, like dark leafy greens. If you're taking, I think it's a thyroid medication, it's some blood pressure, because you can't have grapefruit with this particular medication. So it's thyroid medication, right? Not thyroid, blood pressure medication. You can't have, because grapefruit. I'm sorry, Dr.
With statins, you cannot have grapefruit with statins.
That's what it is. And then I think lisinoprils give you coughs. Like it starts to make
lisinopril cough.
Yep. And you kind of the bradykinin. Yep.
So there's so many things that you have to consider when you start doing something, especially if you're already a healthy individual, because that is scary. I don't want to be stuck with something because I started taking something. Now I may be forced to take this because, you know what I mean? It can be a scary thing when you don't know what the long-term effects are going to be of a drug.
Yeah. Well, and
that's an interesting. So you wonder what the solution would be to that. That would be really tricky. How would you resolve that?
Ethically, if I'm not mistaken, because there's certain things that you're not going to be able to do ethically. And obviously in certain animals, it's not going to give you what you need, because a lot of times they'll use different animals to try to see if they can replicate something in a human, but then it doesn't all, you know what I mean? I don't know if rats cough, but if we give lisinopril to rats, are they, you know what I mean? So
That's a great question. Does anybody know?
I'm supposed to be asleep at 3 o'clock in the morning, but me instead. Chat GPT, do rats cough? If you give lisinopril to rats, will they cough? So yeah, it is tricky because there's obviously things that you have to disclose whenever you're doing trials, things that you can't do. Yeah, it is tricky. I don't know what's the fix for that.
What do you think, Mitch?
Yeah, I mean, you have a pretty good question there. But to the point that I was going to add to that too is these are things that we know about these medications from how we've been studying them. So when we further address that into like the racial or ethnic disparities in the research that's been conducted, especially on some of these old, the older medications that we get, there's more and more separation. I know Hadi, obviously in Raven, you're familiar with what we're trying to do with like Habib's United Research as well, and like the MENA population. They haven't had any representation at all. There's an other category, or like Hadi was just told, it's Hadi's story, but he's essentially just told like, oh, just check the white box because you look more white. You know what I mean? So what kind of quality is that creating for then, how that drug actually interacts with those people? So it's interesting, but not everybody gets that lisinopril cough though, too, to that point. So it is a thing, 100% a thing, but not everybody gets it.
Okay.
Kelvin has another great one out here. Yep. AI data sets need to be vetted for some racial variables, clinical decision support algorithms. Yeah.
So Raven, I did want to bring up one question, and we'll come back to questions. I think we're caught up just about, but I'm trying to think about some of the other disparities that communities of color might have to experience. And it's huge right now. All of the clinical trials in Alzheimer's and diabetes are like huge. We've got the GLP-1 inhibitors, we've got Alzheimer's, we've got all these different things. Do you think that the communities of color would benefit greatly from participating in these trials?
I do. I do think they would benefit greatly from this. Now, in terms of diabetes, unless you're born with it, that starts to become like a thing too, in terms of now it's how is your everyday life? But then that also kind of ties back into, especially depending on what the area is, what type of things are around. Are there food deserts? Are there not, access to nutritious things that's needed to be able to combat this? Because you can be put on a medication for it all day, but if you continue to down this other path, then it's still going to lead to the same thing at the end of the day. So it goes back into, it's an all-encompassing thing. It's the lifestyle choices coupled with any of the things from healthcare that you're going to need to be able to combat that in a healthy way. In terms of Alzheimer's, I'm still very curious about that. In terms of what is it genetically that makes people of color much more predisposition to that? You know what I mean? And that I'm still like looking into, because I would definitely like to know. Nobody in my family has suffered from that. So I've never gotten a chance to really see it up close, but I'm definitely very interested in like researching, okay, what is it genetically that, predisposition someone for Alzheimer's? And I do know that there's some medications, if I'm not mistaken, I want to say, and I think it's Alzheimer's, it might be gabapentin that contributes to Alzheimer's, if I'm not mistaken. And then I think, because I remember my doctor put me on it for nerve pain, but I remember them saying that people who were taking gabapentin long-term ended up developing Alzheimer's, and I stopped taking it.
Yep. I think it was a seizure med, wasn't it?
It's that and for nerve pain, from what I understand for gabapentin. But yes, it is for seizures too.
Yeah. That can get scary.
Yes.
So I look from Alzheimer's.gov from like 2021. We talk about like the disparities specifically with Alzheimer's. The information I found from Alzheimer's.gov was that the Black communities were 2 times as likely to develop forms of dementias, but yet they were 30 30 to 30 or 35% less likely to even be diagnosed with something like Alzheimer's. So it's interesting though that we have like this twice as great, representation in these communities, but yet the diagnosis rate was substantially lower. So those are going the opposite directions.
And I know sometimes there are misdiagnoses too, whenever you start thinking about like some of the racial biases in healthcare. Because sometimes you'll get physicians that feel like people of color don't experience the same thing that a non-person of color experiences in terms of pain, or, oh, they're just malingering. They're not really experiencing these, you know what I mean? So that, and some of those things do result in a misdiagnosis. And then of course that prolongs them even finding out about what's even actually going on with them. And you have to go to 2 and 3 doctors and you try to figure out, what's going on. It is interesting. I would say.
Yeah, I remember reading about that years ago, but like apparently there was like everybody was saying like Black people didn't feel pain the same way, and it's like, well, what are you talking about? What is this founded in? But yeah, go ahead, Hadi.
Go ahead, Mitch. No. Just to that point, there's always this public health challenge, especially with minorities, between prevalence and diagnosis. So with breast cancer, for example, with minorities or Black people, Black women, I mean, they represent at a later stage because of lack of diagnosis, but they have more prevalence of or mortality rate from breast cancer. So there's always this challenge between keeping up with the diagnosis and the prevalence.
Yep.
Yeah.
And I can even there's another strong prevalence in the autism community where seriously the young Black boy is on average diagnosed with their autism diagnosis on like 1 to 2 years later than anyone else, because that's just how they are. It's a racial bias. It's just infuriating to think about that, where our patients are not being treated with equality.
Yeah, it's similar. You find a similar thing with like women and mental health issues. A lot of times, it's like, oh, it's emotions or it's hormones.
Mm-hmm.
It's just completely brushed off by a lot of healthcare providers, which again,
I've heard that many times. Yeah.
Further contributes to mistrust in the healthcare system for sure.
And sometimes even with maybe even the race and ethnicity of the doctor that you have sometimes can also contribute to those things too. If you have a provider who he's an Asian man and you're a Black woman, how is he going to be able to relate to you with things that are actually going on? And this is speaking from personal experience, because that was my doctor. I had an Asian male as a mental health doctor, and I'm like, this isn't going to be very, very conducive for me, because he's not going to understand some of the things that I'm going to deal with as a Black woman, that a Black woman therapist would be able to understand and to know the dynamic of certain things. I feel like that part of it is extremely important to have. And a lot of times what you get in the healthcare system is you'll get African Americans who will have to go into a doctor and they see somebody who does not look like them, and they're trying to tell them about something, and it's like, and it's not that to discredit that they don't know about it, but like Kelvin mentioned, the staff representation matters a lot within that. I know for me personally here in Houston, all of my providers are Black, because that is what is going to make me the most comfortable. And that doesn't mean that I'll just take their word for it. If I still feel like I need a second opinion, I will go get a second opinion by someone else, but not everybody has that option. So now what do we do to help them to be able to get that their first time going so that they feel comfortable enough to continue to go?
Right. Yeah, it's a good point. And, taking it a step further than that, from like the clinical research side, branching more away from the healthcare to the research aspect. We've talked so far on this podcast. I know we're getting a little closer to time, but we've talked about like where regionally people are from, right? Where you're from, where you live matters, or where maybe you were born, where you grew up matters. And one of the things that we've been working on, with DiversiTrials, and I'm heavily pushing companies, like tech companies, and how we're collecting data and what we're trying to push for in data collection, is really granular representation. So like we talk about the MENA population, it's like, okay, well, where are you self-reporting you're from? You know, did you grow up in Lebanon? And then we can start looking at potentially other factors. You know, at least you have that data. The data is available and it's there. And the more granular you have a data, the more valuable it becomes, because you can start looking at it in other ways, in like that public health aspect, or how the environmental health in certain regions or where you're from may be impacting your, you know, your physical health or your mental health even. The same thing with like the Black community. Like, I don't think that's granular enough for the data we're collecting, right? Are you, you know, I talked with, even when I was in New Orleans like 3 weeks ago now, you know, talking with people there, it's like, okay, you're Black in New Orleans. Are you African descent? Are you Caribbean? Are you Haitian? Because you're not, like, culturally, you're not the same. Like, you might gravitate together as a group and feel a little more comfortable, but culturally you're very different still. And where you grow up and where you're from, those are definitely factors that we can start looking into to see, you know, even when it comes to like foods, you know, like we talked about foods, like what are you eating in Haiti compared to what you're eating, you know, somewhere else in like the Caribbean. And we can start kind of piecing some of these things together to find better healthcare pathways and preventative medicine. When we start talking a little bit more about that, and nutritional health, and kind of treating people as a whole, looking at some of those factors.
Oh, big shout out from LaShawn. Thank you, LaShawn. Raven, you got a shout out from LaShawn Sanders. That's pretty awesome. I did have a question for you, Raven, and this goes back to you feeling more comfortable at the healthcare professionals who are Black, because that's what we were talking about. So let's say two scenarios. One scenario is your doctor, you go in there and your doctor says, hey, I think that a clinical trial could help you. I think that you're qualified for it. I'm going to have to refer you away to my white PI over here that you've never met to be a part of a clinical trial. Versus, hey, you may be qualified for a clinical trial. I'm partnering with these people. We can just run the clinical trial right here in my office. I'll be here the entire time. Would you be interested? So my question is, in those two scenarios, how do you feel?
Ooh. So with the first one, I'm skeptical because this is somebody who does not look like me, but because you trust them and I trust you as my doctor who looks like me, then I'm more likely to do it, but with some skepticism. Versus because the second one was my doctor would be there, they would do it in the office, I would be there with my doctor, and I would be much more comfortable with that option. Now I'm less skeptical, and I would be much more comfortable and willing to do it.
All right, scenario 3, and this is why I left it as last, because actually this is how it actually happens right now. So what would happen if some random person talked to you, independent of your doctor, and asked you to be a part of a clinical trial?
What does a random person look like?
I don't know. You're on the phone, so it all depends on how you hear them. It could be someone from a different nationality. It could be somewhere else. But point is, it's just some random person giving you a cold call saying, "Hey, do you want to be a part of this trial?"
No.
Why?
I would be very skeptical of somebody cold calling me to ask me that, because I need more information. Like, did my doctor prep me for this? Did they say, hey, somebody's going to be calling you from this? Or did you just randomly call me and ask me about this? Because how do you know my information?
Yeah. We pulled all your information from the EMR. This is someone from XYZ hospital. Your doctor doesn't even know that we called you, because it was all just, we pulled it from the electronic medical records.
I would be very skeptical, and I'll probably say no.
Yeah. So what you said is the standard, Raven. These cold calls, these people who just come in and say, hey, you want to be a part of something? Let's transact. I need someone in my trial. We haven't talked to your doctor at all. So what do you think? And then nobody understands why we have such a low recruitment rate in these trials.
Yeah. It's shocking.
Yeah.
We're at hours. I want to wrap up, but while we wrap up with final thoughts or takeaways, sorry, Kel, I got to throw this in here. Yeah, They feel very exploitative. We
Yes.
actually did, when we were in Houston, we interviewed Geriatric Jerry is what he agreed to be called. And that's exactly what he experienced. So Fox on CRPN Central actually has a whole little session that he did with Jerry, and he explained his experience with that. He actually got it before I think he got the bill, or before he got his lab results back. He actually got called to participate in trials, which is wild. But while we do our wrap up in the comments, I know Kelvin, you're here. LaShawn, if you're still around, let us know if you guys liked DJ DiversiBuddy. And I actually have like a whole separate song if you want to play it when we leave. When we leave our comments, we'll play it at the end if everybody wants to hear that one. So, Raven, let's send it to you first. Final thoughts. Thank you first of all for coming on and being our first guest, being like one of our very first fans actually too when we were in Houston. Can't wait to get back there. But what are your takeaways from today? I mean, what would you want to leave the community with?
First of all, I'm honored to be here. It was an honor and a pleasure for me to be on here with you all, because you all are amazing and doing great things for the community, for the diversity of getting people into clinical trials. What I would say to people is to talk to those around you, figure out how you can help, get with community, and see how you would be able to help to foster a bridge for people of color or people within your community to be able to be on board for a clinical trial that they feel comfortable and feel safe with. And DiversiTrials is doing a great job with helping to bridge that gap. So just to be able to talk to those around them who may need this and to be able to get them to it, I think would be great. That's what I would leave them with.
Thank you. I love that. Hadi, what's your takeaway from today? Leave us with your wisdom.
Be vocal, be present, and show your passion. I mean, as simple as that. We're all human beings. It doesn't have to be transactional. It just, again, back to your, stand. Always be there, unconditionally. Show your face as a brother, as a husband, as a sister, as a mother, as a friend, as a colleague. As you don't have to just show up under a banner or a business banner trying to do a transactional, activity with the community. Be part of the community as as many faces as you can, and break that barrier. Show your face constantly. Again, one-time thingy, it doesn't work. And again, when it comes to digital health, not everybody is really comfortable in responding to an ad on Facebook. If in my community I don't really see someone and talk to them, pat them on the back, and swap numbers and say, "Hi, Habibi, nice meeting you," it's not gonna go anywhere. So I mean, and again, many people don't really trust digital health or digital ads, and not everybody has an iPhone. So we just have to be cognizant and just think about these things.
Yeah, doesn't have to be transactional. And then here's another great one. Amazing and perfect first guest. Couldn't agree more. Fox?
So, Raven, I have to tell you that a lot of things went through my mind during this podcast. One of the first ones that came through is, oh my gosh, this can be a very uncomfortable conversation for a lot of people. Let's just face it, this is very difficult for a lot of people to talk about. And I think that I really appreciate, as probably the whitest and palest guy on here, that you have the opportunity and you're willing to talk about this with me, and that we can come together and then we can work toward true DEI in clinical research. So I'm so glad that you came to that coffee shop that day. And I'm so glad that you were willing to sit down and talk with us.
Absolutely. Don't make me cry. I'm a big crybaby. I'm a bag of water. So yeah, cut the cameras.
It's okay to cry. We talked about this earlier. I'll keep it short. Thank you everyone for attending our very first official full DiversiTrials podcast. We've got a lot of fun stuff. I'm trying to plan some crazy things. If you guys are familiar with the show Hot Ones, stay tuned because I've got some wild stuff coming up that I'm planning. But yeah, I'm gonna stick with my keyword that I threw under my name today. Just when we're engaging these communities, when we're trying to talk to people and reach out, just be there unconditionally. Just be genuine. If you want to help people, help people. You don't have to get anything out of it, but I guarantee you will. Generally, the more you give, the more you are willing to help and give to people, you often find that returns tenfold. I've found that personally, and I know so many other people who that resonates with. And I don't see why that can't happen in a professional setting. It should, and I'd be willing to bet everything, and we are, that it will. So that is it. Thank you everyone for joining. I didn't get any. All I got was a DJ DiversiBuddy. You just have to show up on time next time, Kelvin, and then you'll know what we're talking about. But
that's Kevin, what we're talking about then.
Check out the replay, Kelvin. There's a replay when it gets posted.
You know what? I'll throw a different video on for you, just because I love you guys so much, and it's our first one. So
DJ DiversiTiam. Yeah, we're coming together, beat by beat, in the streets where the heartbeats meet. Step up, step in, feel the rhythm of change. From the corners of the world, we're rearranging the game. Forces loud, spirit strong, we roll with a diverse crew, breaking barriers, building bridges, anything we do. Rise up, unite, let's make it right. With every word we spit, we light up the night. Light it up, health for all is our call. Let's break down the wall. Together we stand tall. City laws, true city lights to rule. Sights, we're spreading the word. Every boy, every girl deserves to be heard. Equity and health, that's the wealth we distribute. Striving for inclusion, there's no substitute. Drop the beat, not the hook, let's celebrate. Break the stage, never breaks, no time to wait. We navigate the challenges, we innovate. Diverse minds collaborate to create a better state. Yeah, DJ DiversiTiam out.